Okay, well, hey, thanks everybody for joining us today. Mini Grand Rounds is going to be presented to us by Kristina Lehman today. She's one of our medicine pediatrics faculty. She's been with us for over 8 years. She works out at our Hilliard practice. She's got a particular interest and expertise in breastfeeding, and she's going to tell us today why internists should care about breastfeeding. So thanks for joining us today.
Great. Thanks, everybody, for listening. It's pretty exciting to have several people listening who aren't just Heather Saha, who also is interested in breastfeeding. So that's awesome. So today I hope to convince you why you should care about breastfeeding. So as Niraj said, I am out at Hilliard. The ALC after my name is that I'm an advanced lactation consultant through the Healthy Children Project that does some education and certification. And I plan to do my IBCLC test next year. That'll be helpful. So our objectives today are to relate breastfeeding with diabetes, breast cancer, and heart disease, since that's kind of our bread and butter. Talk about some common issues that you might, as an internist, encounter. Talk a little bit about the idea of first do no harm to the breastfeeding relationship, and then get you some more resources and educational opportunities. Breastfeeding and lactation is becoming a big topic. Some people are even just practicing breastfeeding medicine. So in some ways, this is like trying to teach you guys all about cardiology or nephrology in a matter of 20 minutes. So it's obviously very limited in overview, but I hope I gave a lot of opportunities to look at some papers and to get some more information if you want. So there's a recent study that was just published by Bartik that demonstrated, they did it by modeling, so it's not exactly the greatest, study from a perspective standpoint, but they were pretty good about breaking things down and said that the idea of suboptimal breastfeeding, which they defined as less than 90% of mothers breastfeeding to that kind of 6 months or a year, actually results in an increased risk of diabetes, hypertension, breast cancer, and myocardial infarctions. So I put the reference here, and then we'll break it down a little bit. These are some of the studies that they used to do that modeling. So basically, we know that there is improved glucose tolerance and insulin sensitivity while people are lactating. So if you look at this is from the Nurses Health Study. If you look at the age-adjusted hazard ratios, perfect. There it is. You can see that if you're looking at mothers that didn't breastfeed at all as your one, if you get out even 24 months of breastfeeding, your hazard ratio drops to 0.41, and that's even if you do covariate analysis and things like that, drops to 0.47. So there is a statistical significant decrease in the risk of diabetes for mothers that have breastfed, and there's the paper if you want to look at that more. Breast cancer is something else that is definitely up and coming and talked about more and more. So over a lifetime duration, if you breastfeed up to 6 years, your relative risk of breast cancer can drop to 0.7. Actually, even here at OSU, Sully Brill and I and some of the ladies in high-risk breast cancer oncology are starting off by doing a study about just surveying mothers about their knowledge of breastfeeding and the reduction of breast cancer, just to see if any of this information is out there, because we don't think a lot of this information is out there, that maybe mothers would make different decisions for themselves regarding breastfeeding if they knew about the protection from breast cancer. This was decreased risk of hypertension. So if you breastfeed for over 6 months, you do have it's kind of the inverse here. So if you breastfeed over 12 months, they've got your hazard ratio at 1, so it's a 1.27 if you did not breastfeed at all. And then myocardial infarctions as well. So there's a reduced risk of myocardial infarction, that reduction with longer breastfeeding. And I think one of the interesting things about this too is that a lot of these things are cumulative for longer rates. So we often say, oh, you breastfed for 3 months, or you breastfed for 6 months, and that was great, and you did a great job. And it is. I mean, breastfeeding is hard, and so anything that you can do is great. But every month that you breastfeed longer does have additional effect, both for the diabetes, myocardial infarction, breast cancer, all those things. And a lot of these were cumulative durations. So say you had 2 kids that you breastfed for a year each, then you would get the 24 months kind of a thing, looking at that. So going to some common things that you might encounter as a primary care internist. So I think probably one of the biggest things would be mastitis. So if you haven't treated this or looked at this recently, So that's inflammation of the breast tissue. Usually it's related to nipple trauma, so if there's a poor latch, if there's stasis of milk. So the common thing to think about this one is the mom that the baby all of a sudden started sleeping through the night, whether that's because she was sleep training or whether the baby just started doing that. A resident on a really busy service that just couldn't get away to pump and so didn't pump as soon as she needed to can then get to a clogged duct and incomplete emptying, and therefore the milk backs up and then they get infected. Symptoms, usually redness, pain, swelling, really bad getting to systemic flu-like symptoms. Moms feel like they've been hit by a Mack truck, headaches, fever, really feel bad. The number one treatment is really self-care. So it's kind of stop everything that you're doing, get some rest, make sure you're drinking fluids, make sure you are just taking care of yourself and calming down a little bit, getting enough sleep, take your non-steroidals, heat, ice, massage, whatever you need to do to get the milk out. So if there's a clogged duct, you have to get that clog out. So you can massage. A common one too, if people feel like, or call you and say, oh my gosh, I've done everything else. Backside of an electric toothbrush, that vibration can help break it up as well. So that's another good one for those phone calls. But whatever you have to do to get that milk out is really important because you have to have that frequent feeding or expression of milk. And then antibiotics when indicated. So more and more we're looking at a lot of this really is inflammation. So you don't necessarily need the second that they call and say, oh my gosh, I just woke up with a fever and I feel horrible. It's totally reasonable to say, I need you to massage, I need you to pump, I need you to change baby's positions, and maybe I need you to see an IBCLC to talk about latch. I need you to get that milk out and take some ibuprofen and see how you feel. But definitely antibiotics if it's going over 24 hours or seems pretty severe. So usually it's Staph aureus, strep, or E. coli, usually penicillin resistant. So the gold standard we usually talk about is dicloxacillin. What I have run into problems with that is that it's fairly urgent that they get this, and most pharmacies don't seem to carry Diclox, which kind of defeats the purpose. So often I use cephalexin, which is perfectly fine to use as well. If you have somebody with some severe penicillin allergies, you can use Clinda. If you have somebody with MRSA or suspected MRSA, so if you have like your resident that's on their ICU rotation, you might want to think about Bactrim or a nurse or something like that. But caution using with those babies that are less than 30 days of age, because if mom takes a Bactrim, then baby gets exposed, and then we have issues with possible hyperbilirubinemia. Hopefully these slides will stay available for everybody, that you can find it. And I'll talk in a minute more, but at the bottom there is the link for the breastfeeding medicine protocol for mastitis, which is a great reference. If it's not responding, that's when you may want to say, okay, maybe this is MRSA. So I had him on Diclox or on cephalexin, and I'm going to switch him over to Bactrim. The other thing is an ultrasound to evaluate for an abscess, because those can happen. And obviously, if there's an abscess, it needs to get drained. The other thing is making sure mom is actually listening to you, doing the other things. You cannot just take antibiotics for mastitis and it's going to go away. Like, are you massaging? Are you emptying? Are you taking ibuprofen? Are you taking a break? Because if you don't do those things, the milk is going to stay there, and basically it's just going to be like a little pus pocket and not get better. And it's really important to remember, too, that milk is safe for a well baby to drink. So I wouldn't necessarily give this to a baby that's in the ICU with necrotizing enterocolitis, but a well baby that's home and thriving, it's perfectly safe for them to drink that milk. Something else that you may come up with is contraception. So I know I do a lot of that in my practice, and a lot of you have middle-aged women that you may be dealing with that as well. So the goal of contraception is really to kind of achieve the optimal birth spacing. I always say the only thing worse than contraception affecting milk supply is a pregnancy affecting milk supply, because that will probably make it even worse. You want to use an effective method. You don't want to affect their breastfeeding relationship, and you want to use something that's suitable for her woman and her partner. So abstinence is a great form of this, but that may not be exactly suitable for woman or her partner. Multiple methods are available. Don't forget about lactational amenorrhea. It can be really effective if they're fully breastfeeding. So I put there at the breast, because there is this kind of push, especially in the United States, towards exclusively pumping. And we don't know that that does the exact same thing as the baby going to the breast. So there's not necessarily that feedback between mom and the baby. There's not exactly the same hormones necessarily released. So a baby that is directly breastfeeding is not receiving any supplements, is not going more than 4 hours between feeds. So if a baby is sleeping through the night, 6 or 8 hours, all bets are off. They need to have not resumed menses, and it has to be within the first 6 months after birth. So if you have a mom that baby is, 3 months old, breastfeeding around the clock, at the breast, hasn't had a period, lactational amenorrhea is actually not bad. If you have a mom that maybe even her period's not back, but it's in 9 months and they're doing some bottles, that's definitely not somebody that you want to be using this method. Barriers are great. Again, getting back to the kind of suitable for woman and partner, whether or not that works or not for them, but that can be a really good option. And then, of course, we have our hormonal options. So the most common that we use is progesterone only. It is the least likely to affect milk supply, but the big thing I want you to take away here is that it still can. We don't necessarily know, but it looks like some moms have a big sensitivity to progesterone. And if you get into the kind of biomechanics of breastfeeding, progesterone is huge as far as establishing that breast milk supply, but also inhibiting it. So some moms seem really sensitive to this. So if you put them on progestin-only birth control pills and they say, oh my gosh, my supply just completely plummeted, or they got an IUD placed, don't say, oh no, literature doesn't support that, you're fine. Listen to your mom and say, okay, well, if that's important to you, what else can we do in talking about that? The daily pills are really sensitive to timing when it's progesterone only, so be careful with that you need to have a really mom that's really reliable and is going to take that same time every day. IUDs and implants are great, but they do have to be inserted and removed by a healthcare professional, and right now we don't have a lot of people in Gen Med that are doing that. So it may be getting into their OB and things like that. And again, there are some, at least case reports of it affecting people's supply, which may reverse once they have it removed. The FDA is currently has kind of a watch on them so people can report if they're having problems so they can see what's going on. Injections like Depo, it's good, but it's not easily reversible. So they're kind of stuck with that for 3 months, as well as return to fertility after, you take an IUD, a Mirena IUD out, and they're immediately fertile again, but Depo may not be so much. And in general, progesterone just can have some undesirable side effects with mood and bloating and cramping and bleeding and things like that. Combined estrogen and progesterone, which we typically use because it's so effective, is going to affect milk supply. Occasionally, if you use it with a mom that already has resumed her own periods and is cycling regularly because she has her own estrogen and progesterone, sometimes they do well with that. But in general, we try to avoid the combined ones. Another big thing is antidepressants and postpartum depression. So this may be for you guys, especially like a mom coming in with vague other complaints. I'm having headaches. I'm having any number of things. Think about that recent baby. Think about, having her do the Edinburgh Postpartum Depression Scale, which is easily accessible online. It is billable, so feel free to bill that. SSRIs are completely safe in breastfeeding, and the mom needs support too. Again, you can't just say, oh, here, take this pill and you'll be fine. POEM is a local group. It's the POEM is Perinatal Outreach and Encouragement for Mothers. We had them come do a talk for us with the MedPeds group, and they are an amazing resource. They have peer-to-peer mentors. They've got lists of counselors in the area. They are like, okay, you have United Healthcare. These counselors are under that, and here's who can get you in quickly. I mean, it's like super, super helpful. So they're great, especially if it's one of those kind of like, I need to be hands-off and hand them to somebody. They are the place to hand people to for that extra stuff. And at the end of the day, do not be afraid to treat these moms. Postpartum depression is a big deal. It really does affect our mother's health. It affects the baby's health and upbringing, and it can affect the breastfeeding relationship as well. So then this is probably the biggest reason I'm doing this talk is the idea of first, do no harm. So what do I mean by that? So as physicians, let's be honest, we receive very minimal education about human lactation. So a lot of times it's like, oh, well, it's better safe than sorry. Why don't you just stop breastfeeding, or why don't you pump and dump? We get this all the time when we're talking about radiology procedures. They're like, oh, well, our policy is this. Well, the American College of Radiology has protocols for breastfeeding, and a lot of people don't like to follow them. So thinking about, I guess my big thing is think before you answer. If you don't know the answer, it's not just say like, oh, just pump and dump or just stop breastfeeding. It's try to find the answer out. And I am definitely a resource for that for all of you as well. Remember that expressing milk or using formula is not without risk. So a baby that's usually directly fed at the breast, they can have bottle refusal. If mom all of a sudden is pumping when she's usually directly feeding, she can again get mastitis or clogged ducts. We're talking about a mom that needed a radiology procedure or needed a new medication or needed something. So that's a mom that's already kind of at risk for some reason. So you're adding extra stress to her. And remember, formula is a human milk substitute. I could, again, do an entire talk about, what are risks of formula. And it's not that it's the devil and it's not that it's evil, but it is a human milk substitute. It is, should be looked at as a medication. I sometimes liken it to the idea of like somebody that has reflux. I think this is a common thing that we have. They want to keep eating their pizza at night, and so they just want to take a PPI on top of that. So sometimes it's those kind of ideas where, it's like, well, if you just stopped eating the pizza, then you wouldn't necessarily need the anti-reflux medicines. If you did some different things with breastfeeding, you may not need the formula. When patients get conflicting information, there's also that kind of potential for harm and mistrust. So I don't want any of you to get set up in a situation where the patient says, okay, well, my lactation consultant told me this, and the radiology tech told me this, and my doctor told me this. So I think the more you know and the more you kind of can back your stuff up with references and resources, then you won't be in the situation of them saying, well, he told me the wrong information, or she told me I should do this, and they were wrong. So if you don't know, don't guess. The answer is almost never to pump and dump. If you have never pumped breast milk out of your body, you absolutely don't get to tell people that they should pump and dump, because it is not an easy process, and it's a part of your body that goes into a bottle and then feeds your baby, which is a part of yourself. So just the answer is almost never to pump and dump. So where can you get more information? So for medications, my go-to is Thomas Hale with infant risk. So there's a couple different options that are super easy and really, really great. One is there's a book that he publishes about every 2 years called Medication and Mother's Milk. So this is a good thing, too, to have at each of the offices for the nurses to have reference to. He breaks down things into a different category, these L categories, L1 through L6. L1 is totally fine, no problem. L2 should not be a problem. L3 is if the benefits outweigh the risk. L4, you're getting a little bit fuzzy. L5 and L6 are, really try to avoid unless you really need to. So it's a much better breakdown than the pregnancy and breastfeeding categories that are currently in pharmacology. So there's the book. There is a website. They have a phone number, and you literally can call them and ask them, like, I have this patient, they're on XYZ, the baby's this old, what should I do? And they will completely tell you what to do, which is wonderful. There's also an app for your phone, which I highly recommend. It's about $10. So, but if you think about like it's a one-time thing over your kind of career, that's not a big deal. It actually includes pregnancy for second and third trimester. So I find myself using the app very frequently. So that is something that I would recommend if you have a younger female population, or, maybe to help nurses in the office get, or somebody in the office to get, so you have that as a reference. LaxMed is another one, so that's kind of more through the government. It's good. I don't find it as helpful as infant risk personally. There's an app for your phone, but that is definitely a free option if you're looking on a regular basis, on an intermittent basis, I guess, for things, and you don't want to get infant risk. Radiology has, again, contrast media information, and so that's a reference to that. It's on page 101 that talks about breastfeeding. Again, the answer is almost never to pump and dump. So generally, it's perfectly safe, but if you need your backup for that, that's your link. The Academy of Breastfeeding Medicine is another place that has a lot of great resources for you, so bsmed.org. There's an annual membership and meeting. There's a breastfeeding medicine journal, so if you're into lactation, it may be something to consider joining. But the most important thing for you guys, I think, is that there are online protocols that anybody can access that have mastitis, anesthesia, contraception, all sorts of different things. So if you're like, oh my gosh, I have this breastfeeding medicine, and I know Kristina came and talked about stuff, but I totally don't remember what I was supposed to do, go to the online protocols, and you can look up information there as well. Know where to refer your patients. So Heather Saha is also a certified lactation counselor, and so she and I are available for lactation-related consults at the Hilliard office. We're working on getting an actual templated spot, so it's a little bit easier for other offices to schedule, because right now it's just kind of on a PRN basis, which just makes it hard, because it's like, can you see this patient? Sure. When can you see them? And adding them on. But I actually had my first consult from Mike Langan, thank you very much. The other day, he had a mother of a 2-year-old that was trying to wean and was having a lot of pain and engorgement. And so he sent her over to me so we could talk about that. So that was great to be able to help out somebody in one of the other clinics. OSU does have an outpatient lactation clinic, but as I note here, it's young. It's run by the inpatient lactation specialists, IDCLCs, and they're doing okay, but they're young and they need some more practice. Riverside, which, we hate to refer outside, but at the end of the day, the patient needs what the patient needs, and they have an excellent outpatient lactation clinic that I send a lot of people to. There's many IBCLCs in the community. I'm gently saying that they have varied experience. Some of them have certain things that they're passionate about. IBCLCs can come from any number of different places. There are MDs that are IBCLCs, there's nurses, there's dietitians, there's lay people. So just, kind of be cautious with that. And then there's community support groups, there's Little HE League, there's several other ones in the area. And then I know Chris Hanks had called me out at one of the big group meetings that the health plan is doing the Buckeyes for Breastfeeding monthly group at Hilliard that is run by me and Heather Saha and Becca Rudisil up at Stonebridge OBGYN. So if you have anybody that's on the OSU health plan, whether it's faculty, residents, patients, they can reach out to us about that group. So say you want to learn more. So maybe I, picked your interest here a little bit and you actually want to do a little bit more learning. So self-directed study. So WellStart is free. It does a really great job of giving you some good baseline information, and it's good for baby-friendly accreditation. It takes a couple hours, but it is, again, it's free, so it's very easy to say, okay, I'm just gonna get some more information here. Breastfeeding Consortium is $99, but you could get 20 credits, and anybody that's med-peds, they do have MOC points. I think if you pay $129. But so that's a little more robust, but it's not terribly expensive. The Milk Mob is starting this idea of a breastfeeding champion program. So the founder of that is in the Academy of Breastfeeding Medicine, and so I'm in contact with her. They're just getting off and running. So I know I'm interested in learning about doing the teaching part of that, so that maybe we can have, at some point, our nurses take the Breastfeeding Champion program, or at least get just more information so that they are more equipped to deal with phone calls and things like that. And then what I did was through the Healthy Children Project, they do the Certified Lactation Counselor, and they have a few other courses, including the Advanced Lactation Consultant. That's the kind of next step up. So last but certainly not least, I ask that everybody support your colleagues and residents. Many women really feel isolated and guilty when they're expressing milk for their babies, and we can make them feel worse about that if they feel like, okay, I'm not making my RVU requirements, I'm, stepping away from service or something like that. So it's really important to be supportive of them. As we just saw, they personally have medical benefits, so they have decreased risk of diabetes, high blood pressure, breast cancer. There's benefits to their baby. You'll improve your morale significantly by encouraging mothers to do this. So if you see, a resident or one of your colleagues that maybe seems kind of flustered and, say, hey, do you need to take a break right now? Do you need to go make milk for the baby or make a bottle for the baby or something like that? Share your support and what a wonderful gift they're giving their baby and themselves. Encourage them to take those breaks to pump and lean out of work for a short period of time. At the end of the day, it's usually about 9 months because they come back at 3 months, and then it's only until about 12 months that most moms pump. So it's okay, telling them it's okay to kind of take that time for themselves. And then connect them with someone who's been in their shoes. So if they're a nurse or an MA, try to find somebody else that's that. If it's a resident or a physician, connect them with somebody else who's done that. I help administrate an online group of physician mothers. It's called Dr. Milk. So it's all doctor mothers interested in lactation knowledge. So it's always great to get moms, resident moms and colleague moms hooked up with that. So in summary, breastfeeding, just remember that it's the gold standard for infant nutrition. A lot of times when we look at these studies that say breastfeeding reduces risk, we can also look at that in the inverse, that formula increases risk. So instead of saying breastfeeding decreases the risk of mother getting diabetes, we could say that using formula increases the mother's risk of diabetes if we're looking at it as a gold standard. So there are risks for the mother's health to not breastfeed. And as a primary care internist, you will see some lactation-related issues, and you really should be equipped to answer those with evidence-based answers. So don't play it safe and tell moms to pump or dump and wean earlier than they are desired. Know your limits. Refer to those of us that can answer her questions and support.
Great. Thank you so much. Is that the last slide?
I think so.
Okay.
No, there's that.
I was wondering where the rest of the slides Sure.
This is the last one. So this is why I do what I do. So the October breast thing was just hilarious. I just couldn't resist. But that's Will in the top left. He's 5. I breastfed him until he was 3. And then Oliver is in the bottom right. He is 10 months old and still going strong. So that's why I do what I do.
Great. Could you go back to the first slide? So I'm going to start the questions off. Use the up arrows, I think. So. And I'll get us there. So I'm going to just start off the questions here. Let me unmute everybody's phones first. I already did that. So quick question for you. Can you talk about osteoporosis and what happens to women when they're breastfeeding, as far as what happens to their bone health, and then how quickly does it rebound after? And then more specifically, what happens if a woman breastfeeds all the way to the point of menopause? Does that have a negative or positive or neutral effect on long-term bone health?
So that's a good question. I'm not super well versed in the bone health issues. I do know that during lactation, generally speaking, mother's bones become thinner, but it's a physiologic state. So if we look at kind of what our bodies are meant to do, before contraception, before formula, before all those kind of things, mothers would breastfeed their children. The average age of human weaning anthropologically is 3 to 7 years of age. So mothers would have breastfed their first child until they were 2 or 3, and then they would have gotten pregnant again. They would have been pregnant, they would have delivered, they would have breastfed that. So I know the important piece of it is that the reduction in bone density is a physiologic state, and they generally do recuperate that well. And that there's multiple things between all the hormones, estrogen and progesterone, but I can look into that more and get more information.
Okay, I think that'd be interesting. I mean, you never hear it as a risk factor.
Correct.
When you're stratifying patients for treatment. You don't ask those questions. So
no, we don't.
It doesn't have a negative effect, but physiologically you think it would, especially if they nurse until menopause.
Yeah.
So. Okay.
And some women do. I mean, you have some women that will say, I breastfed for like 17, I was either breastfeeding or pregnant for like 17 years straight. But that also is why we talk about birth control pills somewhat being protective, because, you know, again, historically, our bodies, we were either, because there were so many infant losses and people had so many babies, that we were pregnant or breastfeeding all the time. So we didn't naturally cycle. So that's why some of that is an increased risk of ovarian cancer and breast cancer and endometrial hyperplasia if we cycle too much. So I will look into that, though, because that's interesting. I've not looked at the bone health aspect of things.
Well, let's open up to other questions.
Kristina, this is Stephanie Lawrence. I have a quick question for you.
Yeah.
So for some infants who don't take the vitamin D by mouth, I tell the moms that they can take extra vitamin D, like 6,000 units daily. This is sort of along the lines of the bone health. But are you aware of any sort of monitoring that I should be doing? I usually will check a vitamin D when the baby's about 6 months in mom, but should I be monitoring that more closely, or is this a recommendation that you've been making at all to moms?
Yeah, so there was a study published in the Pediatrics by AAP that looked at the safety and the efficacy of the vitamin D in mother. So as I usually try to remind my moms, the breast milk is vitamin D deficient because mom is vitamin D deficient. The system is not broken. The body does not make vitamin D deficient milk because it just does. It only does it when mom is deficient. So yes, I think checking mom's level is never a bad idea, both before and on the supplement. But the studies showed that you don't have to do that it is safe to treat mother and it is efficacious for baby if mother takes 6,400 international units of vitamin D daily.
Thank you.
Other questions?
I stumped them.
You know, this is probably a question that comes up a lot more often for our medicine pediatric colleagues. General internist probably doesn't speak, because a lot of the questions, I think, from our nursing moms usually get directed through either their OBGYN, specialist, or if they have support network outside of the medical system. So I don't think general internists commonly get questions, but we definitely have to be aware of medications. That book that you referenced, isn't it really expensive? It's not something that's, my recollection is it's over $100.
I don't think so. I want to say around 70 or so.
Oh, is it? Okay.
Yeah.
And do you have those in your med peds clinic?
So I now, well, I previously did. I used to buy a copy in the office, but now I have the app on my phone. So again, I paid $10 once, and it's actually updated, whereas the book is updated every 2 years, and you have to buy a new book. But so I personally use the app and too, when you're on call, like if you're not in the office, that's where I run into issues before. And I definitely agree that I know that the internists necessarily are getting a lot of these phone calls, but I think with probably more people getting primary care providers, more people being insured, getting probably somewhat of a younger population, at least that's what I'm seeing amongst my colleagues that are accepting new patients at Hilliard, there's no reason we can't answer these questions. So, we don't need to necessarily pawn them off and say, I don't know, go talk to your OB. Like we take care of women's health. And
yeah, where we do intersect more commonly in my experience is women planning on becoming pregnant.
Absolutely.
And that to me almost seems like the more important. Hey, folks, if you're going to talk in the background, please.
Sorry, I'll move.
Mute your phone if you're going to be talking in the background. That'd be great. I was just saying, a lot of women do come to their primary care doctors when they're anticipating pregnancy,
Sure.
especially if they have underlying medical problems. And that seems like the most important time to at least, you sort of focus on the pregnancy itself, but it's really that first day after delivery, the first hours, that help establish that long-term success and trying to get them to the right resources like you've presented, either you or your colleagues at Hilliard or just some of the other resources in the community. I think that's probably one of the critical messages that I would share from my experience is that moms don't get the support they need early enough, and it's such a stressful time, and trying to get connected with a lactation specialist is not easy when you have so many other things that you're trying to juggle. So, well,
Kristina, this is Sarah Jonas. I have one quick question about supplements. I know we're kind of down on supplements and vitamins these days, but obviously we're still using prenatal vitamins. How long do you recommend that people stay on those prenatals when they're nursing?
I usually recommend that they stay on it through nursing just because of the increased calorie requirement and nutritional requirement. I always tell moms that your body will make the best breast milk for your baby regardless of what you do. So if you don't eat well and you don't, think about the impoverished countries. I mean, they breastfeed their babies and their babies are fat and plump and mom is wasting away to nothing. So I don't think it's ever a bad idea to stay on. So I recommend that they stay on it through the time of breastfeeding.
Okay. And I remembered I'd heard kind of an old wives' tale that if you were pregnant, you got 300 extra calories. If you're nursing, 500 was sort of the requirement. What are the facts? Do we know?
So we do know that the extra calorie expenditure is around that. I guess my personal experience is that I gain weight breastfeeding because I'm like, oh, I'm breastfeeding. I can eat whatever I want. So I generally don't tell my moms unless they're having a hard time maintaining weight that they should increase their calories because they generally will anyway.
And to tag along to that, a lot of my moms come in saying, I just can't lose that last 5 or 10 pounds. And my experience was I didn't until I stopped breastfeeding. Is that a known thing or is that just me?
I know, it's absolutely. The hormones are so off during that time that I think it makes it really hard. And your body, again, knows that it's trying to provide that breast milk for somebody else, so it's going to hang on to some of that cushion. I don't think we know why, but some moms do that, and then some moms can't keep weight on to save their lives no matter what they eat. So I definitely look more at the individual woman and say, okay, where's your weight at? But yes, if they're saying I can't lose that last 5 to 10 pounds of their breastfeeding, then I definitely will counsel them that it may not be until you stop breastfeeding that you actually will lose that.
Okay, great. Thank you.
Kristina, this is Katrina. I have a couple things to bring up for you. The first one being I really appreciated this talk, just having been over at CarePoint East now for the new 2.0. I've come across at least 2 instances where folks were trying to treat someone who was breastfeeding and the postpartum period had higher blood pressure and trying to counsel the residents on how to choose the right medication and not just go for that thiazide or something along those lines in a woman who's lactating. So I do think this is a very important topic, and I just want to say thanks again for kind of putting it out there for folks to have some resources at their fingertips in the clinic. The second thing is I just wanted to ask you about we talk a lot about the postpartum period right after or right when mom's going back to work and screening for depression. I'm also starting to see a lot of moms that seem to kind of present with more of those depressive symptoms as they're stopping breastfeeding, whether that be at 9 or 12 months. And I just wanted to ask, you know, is that another good time where we should start looking back at the depressive screen again, or at least keep it on the radar with moms, like constantly asking them how they're doing with that breastfeeding? Is there any research on that, or is that just something I'm noticing in the clinic?
I don't know that there's specific research, but I mean, we do know that there is that DMER response that is a dysphoric milk ejection reflex. So there are moms that when they breastfeed and have that letdown reflex, that actually will feel just feelings of dread and doom and feel completely horrible. So I would say that we know that there's a deep interaction between mood and the serotonin hormones and breastfeeding. So it definitely is reasonable. And it also kind of makes you, for me, it always question, okay, so why are they stopping? Are they stopping because of perceived low supply? And then is that a sense of failure on their part? Or is it that work is so stressful? Or is there something at home that's going on? So how much of it is direct breastfeeding related versus how much it is the whole motherhood thing? Because I don't know about you, but I think probably 6 to 9 months into motherhood too, it was like, wow, this isn't ending. It's great on one hand, and I really love it on one hand, but on another hand, it's like, wow, this is really hard. So, you know, I think you're right, though, kind of following up with those moms all along and providing support for those moms to say, hey, how's it going? How's that transition to motherhood going? How's the breastfeeding going? Are you kind of meeting your expectations and your goals of things is really important.
Thank you.
Okay, we're getting close to the end of the hour. I'm going to formally thank Kristina for joining us today. Great topic, and thanks for all the resources.
Yeah.